Morning everyone. Today we have a class on PCOD, which is polycystic ovarian disease, ectopic and twin pregnancies, and gestational trophoblastic diseases. So this is quite a wide range of topic, and I'm sure you are well versed with the ovarian tumors by this time. So these are basically the first three topics which we are going to discuss today. The other simpler ones. So I'll just start with the PCOD first, and then one by one we will gradually go into the depth of each of these diseases. So what is PCOD? It is the most common endocrine disorder. This is very, very important to understand that this is endocrine disorder, and which has a high impact on reproductive, metabolic, and cardiovascular health of the affected girls and women. Now we will discuss into the details of pathogenesis, how one endocrine hormone, when it gets dysregulated, how it affects the health, complete overall health of all the other systems in the body. So let's talk about the epidemiology. It is pretty common, as you can see. The incidence in India is about 3.7 to 22%, and it is high, but in Europe it is 19.9%. In India, about 2 in every 5 adolescent girls, all the teenagers, are having a chance of PCOD, but in the adult women, it is 1 in 5 percentage. So what are the drivers? Why the PCOS suddenly has risen so much? Why the boom? Suddenly every second lady is suffering from PCOD. Why? Because first of all, the genetics. People are able to understand the genetics, and there is a rise in the childhood obesity because of the risk in the family eating habits. More of burgers, more of burgers and pizzas, and all these habits, they actually cause increase in obesity, and then the symptoms of PCOS. And then we have the early onset of insulin resistance that happens because of more of glucose intake, of more colas and all those drinks which are being commonly used, lead to the more rise in glucose, with the result of insulin release. And by the time you become late 20s, you're already showing the insulin resistance, and then after that the diabetes mellitus follows. Then we have the improved diagnostic facilities also. People are also very aware of all these conditions, so they get back and they really want to diagnose themselves. So the rate of diagnosis in cities like Bangalore, they are very, very common, and so that helps in the early diagnosis of PCOS. So improved patient awareness, as we have discussed, are the other causes which lead to the early age of the onset of PCOS. So the dietary food habits, as I've discussed, the Western diets, which are rich in carbohydrate and fats. The combination of carbohydrates and fat is very, very deadly. So this causes an increased weight put on, increased in insulin resistance, and then all this diabetes will follow. And then nowadays the push button of the lifestyles, like reduced physical activity, all the time working, especially the software engineers, they are sitting all the time either in front of the computer or TV, and there is less physical exercise, which also leads to this condition. Then the stress also are particularly is very, very important in stimulating this sympathetoadrenal activation, and then precipitating the insulin resistance in the long term. So the other factors are the malnutrition, low birth weight, dyslipidemia, subclinical inflammation, as we can see in C-reactive proteins, and then now there are so many markers which can tell you about the inflammation. So all these factors actually lead to PCOS. So genetics definitely have a role. There is mutation in different receptors, which we will talk in the next slide. But if one sister has it, then there is a 40% chance that the other sister will also have it, and in these cases 10% of the chances that mother also have the disease. So it is inherited in an autosomal dominant pattern, or the inheritance. Now let's talk about the mutations. The mutations can be seen in any of these receptors. You can see the insulin receptor substrate, or calpain-10, or PRARA, gamma, or PRI-R3. So all these receptors, they will show the mutation, and there will be genetic mutation in these receptors, and with the result, even if the insulin is present, it is not able to bind to those receptors, and with the result, the action of the insulin is not being taken off. So what happens is insulin level is high, and still the insulin is not able to do its work properly. So there will be a androgen biosynthesis, secretion and transport, and also there are other hormones like SHBP, very important, sex hormone binding globulin, and the androgen receptor, which are mutated, and these are very important causes of genetic mutations. So follistatin gene is nowadays they are saying it has the strongest association with PCOS. So leave behind the genetics now. Let's talk about the pathophysiology. So now all these factors which we have studied, what it will lead to? It will lead to the excess ovarian androgen secretion. Ovary is not supposed to secrete androgen. It is supposed to secrete what? Estrogen and progesterone. So all these factors leads to the secretion of androgen from the ovary, and the ovary, you can see that there are multiple cysts in the ovary. If there is an increased androgen secretion, there is an increased testosterone levels. So when there are increased testosterone levels, two things happen. LH levels will rise. So when LH level rise, what will happen? Progesterone will go down or not? Yes. FSH and LH, estrogen, progesterone, I hope you remember the pathway from your physiology chapter. So when LH is high, it will again cause the increase in testosterone. So all the cycle will keep going, and then we have the insulin resistance, which develops because of the increased testosterone. And when there is an insulin resistance and increase in testosterone, it leads to the anovulation. Increase in LH causes the anovulation. Now because of the insulin resistance, more insulin will be seen in the circulation. With the result, there is a decrease in a sex hormone binding globulin. So when there is a decrease in this protein level, so there is no protein available to bind to the testosterone. So with the result, there is a free testosterone in the circulation, and this free testosterone gives rise to the symptoms which is known as hirsutism. The female will start showing the male features. Okay. So then you can see dietary and genetic factors also lead to insulin secretion. So you can see the basic thing which happens is insulin resistance, which causes all these symptoms. So let's talk about the clinical features. Now you can see this is a table in which there are 4 different clinical symptoms. The first one is a hyperandrogenism. So what happens? Testosterone level rises. With the result, there is a hirsutism, acne, alopecia. So this is one of the most common symptoms of PCOS. Now LH is high. Okay, so progesterone is low, so estrogen must be high in these patients, and with the result there is amenorrhea or oligoamenorrhea. Now all these things lead to the infertility. When you have a menstrual irregularity and hyper testosterone, it leads to the infertility. And obviously insulin resistance and obesity is following all these symptoms, which leads to the metabolic syndrome. Now out of this, hirsutism is the second most common feature. Obesity is the most common feature seen in the Indian woman with PCOS. Now associated comorbidities. Now what will happen if there is a metabolic syndrome? You will see depression, cardiovascular risk is very high, diabetes mellitus is high, estrogen is high, so endometrial carcinoma is high. So there's a complications in the pregnancy, there will be difficulty in conceiving. Then we have the obstructive sleep apnea, NASH is seen in the liver, decrease in the protein synthesis. So all these symptoms will appear after the PCOS is being diagnosed inside the patient. So now you can see one thing leads to another, and the basic thing is insulin resistance. Now you can say NASH is the highest common disease that we can see. Okay, what is NASH? It is non-alcoholic steatohepatitis. It is nothing but the liver injury which is associated with this non-alcoholic. Okay, so depression 54%, cardiovascular diseases is 1.53, and the type 2 diabetes mellitus, the risk is 5 to 10% higher. Now, how do we differentiate between polycystic and multicystic ovaries? Very, very important question, because every person cannot be having a polycystic disease. So, even though both are bilateral, polycystic should have at least 12 follicles, and multicystic can have multiple cysts. They can be less than 12 or more than 12, it doesn't matter. But the diameter is important. The diameter in multicystic is always more than 10 millimeters, but in the polycystic it is around 2 to 9 millimeters. So the stroma in the multicystic is not increased. Only there is a multiple dilated cyst, huge cyst, and the stroma is not increased. But in the polycystic, the stroma is also increased. Okay. Now, in the biochemistry, I think you know by now that LH has to be higher and testosterone will be higher, and with the result, the other things, sex hormone binding protein and the androstenedione and THAS will also be higher. Okay, so let's go to the next topic, which is ectopic pregnancy. And now the ectopic pregnancy is a pregnancy where the fertilized ovum gets implanted and develops in a site other than the normal uterine cavity. So if there's a pregnancy is happening inside the endometrial cavity, obviously it is a normal pregnancy. But if it happens in the fallopian tube, on the ovary, or somewhere else which is outside the uterine cavity, it is known as a ectopic pregnancy, and it is a serious hazard to the woman's health and reproductive potential, because ectopic pregnancies rupture, and that is a medical emergency. Alright, so we have different implantation sites. First we will talk about the tube. In the tube is 95 to 96% of the pregnancies. Ampulla is the most common site, followed by isthmus, interstitium and infundibulum. Then we have ovarian pregnancies also. I have seen one case of ovarian pregnancy. And then abdominal, you can see pregnancy which is primary and secondary, which is very, very rare. And secondary, it can be implanted on the intraperitoneal or the extraperitoneal ligaments. So in the uterine, if it is outside the uterine, like cervical or on the angular or the C-section site or the cornal site, then also it is known as an ectopic pregnancy. Now this picture very clearly says the one which does not have the round figure, on the left side is the uterus, which is a normal pregnancy. But if you see in the cervical, intramural, interstitium, tubal, intraligamentous, ampullary tubal, fallopian tubes, ovarian, abdominal, so all these are the abnormal sites. So what are the causes of the ectopic pregnancies? The first one is IUCDs, contraceptive devices, PID, inflammation inside the fallopian tubes, any surgeries, any assisted reproductive techniques which are being used for the pregnancy, especially in PCODs. Then late marriages and late children also is one of the causes. The other factors include previous abortions or cigarette smoking or infertility. Then we have a genital tuberculosis, which is the most common cause in India. Then we have adenomyosis of the tube and transperitoneal migration of the ovum. That's what they say. There's an iffy hypothesis that there is an influx of the menstrual fluid which goes inside the tube. So because of this influx, the implantation happens inside the fallopian tubes, or it goes beyond the fallopian tube into the ovary or into the peritoneum. So they say sometimes the implantation site is not ready, there's an increased testicular reaction, so that's why it's not able to implant, or there's a premature degeneration of the zona pellucida, or there's a endometriosis in the fallopian tube. Okay, so this is a picture which you can see. This is a tubal abortion. The fetus has come out from the tube and there's a lot of blood here. It has happened, and this is a ruptured ectopic. You can see if there's a rupture, the patient goes into medical emergency. So what are the classical findings of the ectopic pregnancy? Acute means the rupture. The patient will show symptoms of pain, amenorrhea and vaginal bleeding. So the patient might be in shock or syncope due to some vasomotor disturbances. Alright, so we have to identify the ectopic pregnancies. It's a short note for you, so it's very, very important. PCOD can come as a long note also. Pathogenesis and the etiologies of the PCOS, very, very important nowadays. So the third topic is twin pregnancy. And the twin pregnancy, what are the causes of twin pregnancy? Maternal age, higher race, black races are more important, increased parity, then hereditary, pituitary, gonadotrophin and other ART, artificial reproductive techniques which are being used, it might lead to the double pregnancies. Now in this you have to remember only two things. Now the zygotes can be either dizygotic or monozygotic. Okay, so most of them are dizygotic, and there is a fertilization of two independently released ova by two different sperms. So there are two ovas and two sperms, so it is known as dizygotic, and they are not true twins. Okay, so now you can see they are properly separated. They have two chorions and two amnions, so both the babies are developing separately and they are not a true twins. Okay, now this constitutes about 1/3. So this happens is one sperm, it fertilizes one ovum, then instead of forming a one zygote, it forms two zygotes. Okay, so there is a division, there is a splitting of the fertilized egg after the fertilization. Now in this there will be an almost sharing of the genetic material, but still it cannot be 100%. The discordance always lies. So sometimes it happens because of the teratogenicity of some of the drugs. So in this you can see there is no intervening chorion, there is only amnion which is separating them. So it is known as the monochorionic and diamniotic. Monochorionic and diamniotic. Okay, so this is how we differentiate between the dizygotic and monozygotic twins, and monozygotic twins are they are the true twins. Okay, so this is all about it. Very interesting indeed. Now the last topic is the trophoblastic diseases. They are characterized by pregnancy associated trophoblastic proliferations. Now these trophoblastic proliferations can happen either primarily after fertilization, or they might happen without fertilizations. There are few conditions which are not associated with the pregnancy also. So now one of them is a carcinoma. Then we have the placental site trophoblastic disorder where there is no pregnancy involved, but carcinoma can be pregnancy associated and may not be pregnancy associated. They range from tumor-like conditions to malignancy. So H-mole is the most common complication of gestation. So they can be monitored by measuring HCG levels. We will talk about it. Let's see the classification, histological classification. Number 1 is H-mole, invasive H-mole, choriocarcinoma, placental site trophoblastic tumor, and then we have a proliferative lesions which are not tumorous. They are just exaggerated placental site benign conditions, placental site nodule, and then the unclassified trophoblastic lesions. For your exam purpose, H-mole is very important. Choriocarcinoma can be important for you as a short note. So let's see what is H-mole. It represents a non-invasive, very important, because if it is invasive, it gets into invasive mole. But if it is non-invasive and it abnormal placenta characterized by grossly evident hydropic swelling of the chorionic villi accompanied by trophoblastic proliferation. So normally you should not be able to see hydropic swelling. Normally you should see vessels inside the chorionic villi, but instead of the vessels, if you see the edema and the congestion, and there is accompanied by trophoblast which is seen in the form of syncytial trophoblast or cytotrophoblast, you call it as a H-mole, because they should not be seen more than a particular amount. Now the complete mole, it is characterized by gross hydropic swelling of most of the chorionic villi, and it has a diploid karyotype. So what is the difference between a complete mole and an incomplete mole? You have to know about it. Okay, so etiology is very, very important, how they are formed. Now this complete ones are the diploid ones. So what happens is, how does a complete H-mole is formed? When a sperm, it fertilizes an empty egg. So there is no nucleus inside, there is no 23 eggs in there. So if the sperm is carrying 23 eggs, it goes inside the egg and it duplicates itself. So there is a 46XX, there's only paternal chromosomes. So do you think a baby will be formed with only male nucleus? No, there will be no nucleus, no zygote is formed, but there is a proliferation of the placenta inside the uterus. So how does the lady present? There's a marked uterine enlargement. She will experience severe vomiting, hypertension, hyperthyroidism, and there will be a vaginal bleeding with the passing of the molar vesicles. Alright, so even pelvic ultrasonography will show no storm appearance. So now you can see this is the mole fertilization, and you can see there is a chorionic villi, the grape-like swellings that you can say for a common word. But this is the only thing which is formed with the duplication of the paternal chromosomes, but there is no zygote which is formed in a complete mole. So remember my word, complete mole do not have a zygote. Okay, so now you can see this villi, they are all looking dried up, hydropic, there is no vessels inside it, and there is a proliferation of the cyto and the syncytial trophoblast over here. Okay, so these are the normal villi. And this also, vessels are not very clear. They are usually, when they are full term, there are more than 10 vessels inside a villi, but normally in the beginning it is 4 to 5 vessels. But in this, you can see there are no vessels here, and there is a edema and hydropic degeneration, and there's a trophoblastic proliferation which is much more than required. Then we have the partial mole. It has again it has two components. One will be the normal component and other will be the hydropic component. So not all the villi will be showing a hydropic component. So these will have a triploid karyotype. The complete moles were having diploid, so partial mole will be having triploid. Now let's see how they are formed. When a single ovum is fertilized by 2 sperms, so with the result there are 3. So there is a partial, so what will happen, it will triplicate and it will show 69XXY. So what do you think, a zygote will be formed or not? Yes, there is a male and a female component. There is an egg and the sperm, so a zygote will definitely will be formed, but it will show triploidy, and it might be very this baby also, it doesn't survive, but it will show a zygote. So now you can see this is how it looks like. The villi are less, the normal placenta is also seen in between, and now you can see the picture here. You can see some of the vessels here, you can see this is the vessel here, but rest of them are all hydropic villi, and the trophoblastic proliferation is not that much, and you will be able to see fetal parts on microscopy. Okay, so very, very important. I'll just revise the differences between that. Clinical presentation incomplete, there will be spontaneous abortion and the grape-like vesicles will be coming out of the vagina. And the partial, there will be abortion, but it will be missed or spontaneous, it can be anyways. So gestational age will be around 4 months, and the other one will be around 6 months when the HCG becomes very high in these conditions. So uterine size is often large for the dates, and partial it will be often small for the dates, and the serum HCG is very high in the complete mole because there is no ovum in there. Behavior, so the chances of malignancy will be higher in which one? Complete mole. Complete mole will show more chances to get into choriocarcinoma or other gestational trophoblastic tumors. Okay, so now how do you differentiate between complete mole and a partial mole? But there is one marker P57 which is recently been introduced, and they are expressed in the complete moles. So this is how you differentiate between complete and the partial mole. So what is the invasive mole? Invasive mole is when the chorionic villi are not only within the myometrium, but it has invaded the vascular spaces and it has gone beyond the myometrium. Now you can see this is the uterus, and the invasion has happened into the myometrium and the hemorrhage, and it is even going outside the myometrium. So the villi, they are usually enlarged. okay, and the invasion is seen inside of the blood vessels, the parametrium, and the invasive moles display a pattern which is almost similar to the complete mole, and they can even metastasize to the distant sites, and there's a persistent elevation of beta HCG. So there's nothing new in it, but you should know if it has gone beyond the myometrium, it is known as an invasive mole, and now it is considered a little bit of malignant. It has to be removed. It's still not malignant, but the mole has just invaded outside the myometrium. So this is the last disease of the day, choriocarcinoma. It is a malignant neoplasm composed of trophoblasts arranged in dimorphic pattern, and they lack the chorionic villi. Now you can see there are no chorionic villi, and there is only trophoblastic proliferation, and which may be showing very, very highly atypical morphology. So it is an epithelial neoplasm. It can happen secondary to the normal or abnormal pregnancy, I've told you already. And these are rapidly invasive, widely metastasizing malignant neoplasms. And sometimes a patient may come with a tumor inside the brain, and you might not know from where it has come, or inside the lungs. And you might think, oh, the person has never smoked in their lives, and how the tumor appears in the lungs or in the brain. So when you do a biopsy, and then you differentiate that, oh my God, these are the trophoblastic cells which has come from the uterus, and it might not be associated with the pregnancy. But the good part is they respond very well to chemotherapy, and you can see here the large malignant cells. These are all trophoblastic cells, highly atypical with a high mitosis activity, and highly malignant and highly metastasizing. Okay, so the ultrasound may show small masses in the uterus, and the patient may observe irregular spotting, bloody or brown or offensive in color, and the mets can be seen on x-ray, and beta HCG will be highly out of the limit. It sometimes might come in thousands. So the mets is very common to the lungs, vagina, and the brain, and this is how the presentation will come out in these patients. So we have covered the FGD system, and please read about choriocarcinoma. It's exam question, and twin pregnancies we have covered, and obviously H mole you have understood very well, and the other part was the ectopic pregnancy. I'm sure you will be able to write about it, and then the PCOD, which is again very, very important. So I think I'm going to stop myself here, and I sometimes feel like a radio jockey. I keep on telling again and again, but definitely hope to see you soon, and please study in the meantime. Bye. Thank you.